So we got the hardest part out of the way. Before we started, I spilled coffee on you. You're the first guest that I've spilled or thrown basically a drink at, so that's a good start.
It was an honor. I was worried about doing it myself.
Yeah, thanks so much for being here. I'm sure that you're really excited at this point.
I am excited, yes. Yeah. And coffee smells great, so
okay, that's a good start. I'm going to try to keep it away from myself at this point. I'm not going to touch anything else for the rest of this podcast. So the reason that I wanted to have you on, first and foremost, is because you're our Student Doctor of the Year. And with all the students that we have at the school and all the impressive stories that I've heard, just the awareness that you came out as the chosen Student Doctor of the Year, whatever those stipulations may be, is so impressive in and of itself that I knew you must have had an extremely impressive story and background. And after reaching out to you, I was planning on writing a story at first and just kind of doing a Paige is our Student Doctor of the Year. These are the things that she's done. I realized that there was no way that I could do that without creating basically a novel, because you've accomplished so much already. So I just wanted to start because our school has this standard of recruiting students from the Northwest, bringing them back to the Northwest communities. And the idea behind that is they'll be interested in returning to their hometowns because that's where they're from naturally. Mm-hmm. But you are not from the Northwest at all. But when you graduate, you do want to go back to a Northwest community. And I found that fascinating in and of itself. And it seems like that is driven just by what you've seen in your experiences. So you grew up in San Diego, California, correct?
I did, yeah. San Diego is a great place to grow up. Had a lot of diversity in my friend groups, and being really close to Mexico was a really rewarding experience, and working with Rotary, or the Interact, which is the high school club. Being able to go down to Mexico and being able to see another country and a different level of poverty, and be able to have friends that were bilingual, multicultural, and then moved to Montana for college, receiving an academic scholarship, and didn't know anybody up here, but it was a great experience, and I've loved the Pacific Northwest. And after that, don't want to leave. I think it's beautiful up here, and I really like the people, and being able to be in a community in Yakima where there's also that multicultural, bilingual community, but it's more climate that I like, and then also cheaper rent, especially compared to California.
Yeah, I believe it. Mm-hmm. So before you even moved up to Montana for college and mm-hmm. started to get the experiences that you did, you had done a lot of work in healthcare and just dealing with populations that may have not had the access to healthcare that they needed. Can you talk a bit about that? Was that through high school or?
Yeah, in high school, I think in the beginning of high school, I came in and was interested in community work, and somebody said I should volunteer with Interact, the high school version of Rotary, and getting to see the community projects they were doing, and being able to go down to Mexico really opened up my eyes to issues that I didn't see in my day-to-day life, but that many people were experiencing as their day-to-day life. And then having that experience, was president of Interact and led a lot of trips down to Mexico, and volunteered for an organization called Amigos de las Americas, which is kind of like a mini version of Peace Corps, where I was in a homestay for 6 weeks in Panama and speaking Spanish pretty much the whole time, and it's community development projects. And so being able to, if a community doesn't have, it's community run, so whatever the community thinks is the best project for their community. So if somebody doesn't have bus stops, the community can decide to build bus benches. If they don't have, one of the favorite projects that I had when I worked for the organization in Paraguay, where I was a project supervisor for 3 months, of being able to have the community that kids weren't able to go for a full day of school because they weren't able to get lunch there and the walk was so long. And so the community said, we need to build a community kitchen at our school so that the kids can come to school, have something to eat, and stay the whole day. And so that they matched the funding that came from the organization to be able to build that community kitchen so that kids could stay much longer than a second grade education of being able to stay for a full day, and then for more grades of having that support from the community.
Wow. It's amazing that simple things like that we take for granted
mm-hmm.
are such major obstacles in so many things in life. I mean, even just receiving an education.
Mm-hmm.
What was it that attracted you to that sort of work? As a high school student, I know that, myself in high school, I didn't have any of that on my radar.
Mm-hmm.
Was there something before high school, or what led you down that path?
Well, that's a good question. My grandpa is all of my family is very generous in different ways. My grandpa was very involved in civil rights as a lawyer and worked with Cesar Chavez. And so potentially with that, I'd have to consider that more of what initially started that. I think having those trips to Mexico were very influential of being able to see things that, exactly like you said, that I took for granted that other people didn't have, and why was that, and exploring that more, and having a really good place in high school to be able to have a friend group that explored that together and also had similar values, and to learn from them and explore that discussion, and then be able to have the opportunity to experiences of having additional travel and being able to grow on that perspective beyond just that original thought.
Mm. So in our conversations leading up to this, you explained to me that when you were leaving high school and even when you were going to Montana, you still had this focus on global health. When you arrived in Montana, though, that shifted. What was it about the experience that you had in Montana, the things that you saw, that made you realize that although global health, of course, is still important and probably something that I'm sure you're still really passionate about, there was some sort of a shift that happened? What was that shift?
Yeah, I learned a lot through traveling and being able to see things that you can't necessarily through the media, and being able to have really great interactions with people abroad. I think sometimes we put too much focus on global health missions, and I learned a lot from those experiences. That I did the homestay in Panama, and we did community projects in Paraguay, and then I interpreted in Honduras for a medical group, and also did a medical mission in India, and learned a lot, and it definitely shaped my global perspective. But in college, of having sociology classes and taking a course called Hunger and Homelessness, and learning about the history of homelessness, and then volunteering at that homeless shelter for the class, and then the next 4 years after that, of seeing the level of need that was in the United States as well, I grew up middle class, and so that kind of opened my eyes that, yes, you see people on the streets, but I didn't realize how many families were living out of their cars or living in abandoned sheds, especially in rural areas. Later, when I worked at the food bank, of seeing people that had to have their power turned off because they couldn't afford it, and sometimes due to medical bills, or not being able to afford food, or have to skip a meal because they have to pay for a medication. And that was something I'd never had exposure to prior to college. And so taking the course Hunger and Homelessness and diving deeper into that, and I am still very interested in global health, and I think that there is a greater need globally in terms of the poverty level can be deeper, but I think that I feel very passionately about effective altruism as well, which is kind of high impact philanthropy, not just how can you do the good, but the most good. And so if I spend $1,000 to fly somewhere to do a medical mission, versus I could spend that $1,000 donating that to an organization that does malaria nets for $2 a net, how many more lives am I saving through that effort? And so being able to participate in donations and advocacy and more of that policy in being able to influence global health. But as far as direct service, I feel very passionately about doing that in the U.S., and that this is a culture and context that I understand, and being able to help the people that are in my own community on a day-to-day basis, and being exposed to the food bank, and how after taking that in college, and then having a huge interest in food security, and wrote my capstone on that, majoring in sociology with an emphasis in social justice, after seeing what a need there was, and really wanting to dive into social determinants of health, and seeing how do things like housing and poverty and education and access to food and access to healthcare and a safe place to exercise, how do those influence our health, and how does that vary? And so felt very fortunate of being able to dive deeply into that, and specifically more into food security of especially family food security of parents sacrificing their meals to feed their kids or not always having enough to have their kids have nutritious meals. And then based off of that, going to the food bank, becoming an AmeriCorps Vista and doing a lot of outreach and to college classrooms and some excellent work with clients. And that was something that was eye-opening for me as well, of seeing about 60% of our clients were coming to the food bank because they weren't able to afford food due to medical costs. So either hospitalizations or, medications that they need to afford, or a family member got sick, and some of them didn't have health insurance, but even those who did, of not being able to have affordable health care. And so now they're debating between paying for medication or eating food. And sometimes the medication you have to take with food, and if you can't afford both. So that to me was also, I was interested in social determinants of health, and then diving deeper into some of those issues and the health disparities that were out there during college. And then that year kind of focused me into, I really want to focus on healthcare and access to healthcare, that being a big player of food security is very important and housing is very important, and a number of factors of social determinants of health. But if somebody isn't able to afford their housing or their food because they are paying those medical bills, and that was a much larger number than I realized prior to that year.
Just the medical connection to it. When you went to college in Montana, did you already have this medical long-term goal of becoming a doctor?
Yes. In high school, I wanted to be a physician, and I think that was a combination of things. I've always really enjoyed learning, and I think picking a career that really gets to work directly with people and help people. During college, I kind of debated being a teacher or being a social worker, that those are also professions that I really respect and admire. And seeing with being a physician that you get to apply all of those subjects, and you do teach patients on how to take their medications or on what's happening with their body. With social work, that was something when I was shadowing in college that kind of confirmed my decision to be a physician. Was she says, I feel like I'm a glorified social worker, or I feel like I'm doing a lot more social work than I signed up for. Mm-hmm. Which for me was great. I get to learn about science, and I get to connect people to resources as well. So those are all exciting things for me, and I think being in medicine is a great combination of a lot of things.
Coming back to one thing that you said earlier, and one thing that stuck out to me, you discussed that hunger and homelessness course that you had taken. Mm-hmm. And one thing that jumped off the page to me when we were emailing back and forth was the fact that you took that and it was so enlightening to you. And then the next year you were teaching the course. Mm-hmm. What were the elements of that course that shocked you, that brought you so much passion to go into this field and to eventually teach the course to other people? What are some of the things that you were teaching others that you had learned?
Yeah, I learned a lot. That course is taught by one of my mentors, Daisy Rooks, and in sociology. And the course was held, we had 3 hours once a week at the homeless shelter. And we'd have guest lectures from the community and some people who had experienced homelessness, some people who were veterans, and that it was a really great course in being able to see all the different facets of homelessness, that it's not just the person that you see on the street, which is also seeing in that context too, where in Missoula, not everybody who's sitting on the street is actually experiencing homelessness, versus a lot of that hidden homelessness that I hadn't seen, of families living out of their cars. Mm-hmm. And the number of people that I saw at the food bank too, who that was something shocking to me that I hadn't seen. And being able to, part of the course too is also writing ethnographic field notes, so really detailed descriptions of everything you're observing. And I think having that be a part of the course of qualitative research, that you write down everything you observe and then you look for patterns. And that was a great process for reflection too, of here's everything I'm observing, here's how I'm reacting to it, and how that might influence what somebody else says to me, and really being able to have deep discussions with people who had experienced homelessness, and meeting some people who were 19 and had aged out of foster care. And that easily could have been me if I'd had a different background. If I'd grown up in foster care and had been bounced around house to house and hadn't had the opportunity to get a consistent education or not have my needs met, or some of the more serious factors. And so being able to meet people that I hadn't previously, and the things that they had gone through and how resilient they were, and having that course really be a good place for discussion is something that I really appreciated, learned a lot from, and then really wanted to be able to contribute to that for the next round of students.
It's amazing how it seems like the experiences that we have in life, our president talks about it quite a bit, adverse childhood experiences, and just those little foundational pieces. It's just the effects and the ramifications that they can have long term. And it almost seems like, you know, the odds of being lucky or being unlucky are one and the same. And some people just end up lucky and have good circumstances and others don't. And it seems that is the thing that results in the way that their life carries out. And having that experience, I imagine, especially in such a deep way where you're so connected to those people, must really drive you towards action and doing something, which obviously is exactly what it did for you. One thing that you mentioned was those really detailed looks into people's lives as you greeted them and as you dealt with them, and that translates directly to something that we discussed again before this conversation, which is the approach that you plan to take to medicine. Looking at people outside of, and this is, again, we seem to hit on this every podcast, but it's really important, outside of just the clinic and outside of just the problem that they have, and seeing what shapes their lives outside of the clinic. What are they eating? What sort of stresses are they facing? What is their family dynamics like? Where do they live? Those things are seemingly as impactful to health as anything else. That seems like something that's surprising to a lot of people who look at medicine. They view a doctor as somebody who can fix a problem and then move on from it. I think we have a train coming.
Oh.
This is a challenge of recording.
I can see, yeah.
So in taking a deep look at the people that you were able to interact with in those experiences, you talked about really looking at the lifestyle factors that led them to wherever they were and that influenced their lives. And before our conversation, you had talked about, we bring it up in seemingly every conversation, being an osteopathic college, the osteopathic approach and looking at patients outside of just whatever problem they present, and instead looking at the life that affects them, whatever their, what they eat, what their family dynamics are, where they live. All those different factors are as important as anything else seemingly in their health. Can you talk about that? Because that seems to be a really misunderstood piece of medicine and something that so many people in our school try to push, and I don't know if it's always as successful, because I think people who look at medicine look at it as, you're going to come in, you have this problem, they're going to figure out a way to treat that problem, whatever it is, and then they're going to send you back to your life and you deal with whatever your life is. And that's not an effective approach to caring for somebody.
Yeah, absolutely. I feel extremely passionate about that, and I think having the experiences that I did and learning more about in sociology of here's all the disparities, that there are huge disparities based off of gender, class, race, socioeconomic class, being able to have different levels of quality of healthcare that you receive in addition to other factors, and learning more, there's these disparities out there, now what can we do about it? And I think being at the food bank, and I really got more involved in advocacy and Medicaid expansion as one thing, advocating for our clients there. And I think coming into medical school, really viewing not just helping patients in the walls of the clinic, but being able to see ourselves as community leaders, seeing ourselves as not just diagnosing something and treating something, but seeing if they don't have a safe place to exercise and we encourage exercise, how are they going to be able to do that? We tell them to eat right, but they don't have enough money to be able to buy fruits and vegetables. How are they going to be able to accomplish that? We encourage, if somebody comes in with anxiety or somebody is really stressed because they're at risk of losing their housing or they don't feel safe at home, how are you going to be able to deal with, combat that or work with that patient to be able to alleviate their stress if they're coming home to that every day? And I think that working in the clinic has been a huge privilege, and being able to talk with patients and hear stories and learn things about the world and about them that I wouldn't previously. And I think it's our responsibility to take those stories and be able to change the healthcare system or the greater system and working with our communities, and sometimes needing to work on the state or national level to change those systems to be able to make it easier for patients to be able to have affordable access to healthcare, to be able to have affordable diet, of having fruits and vegetables that's being affordable, of being able to have access to housing, of having a quality education so that they are able to further themselves down the line, or if they're a child, of being able to grow up and have that knowledge to be able to take the best care of themselves and their families. And so seeing for myself that that's something I'm very passionate about, of addressing social determinants of health and advocating for patients on all those levels. And then something with health advocacy that I'm very excited about with our school is, I think overall in medical education, there's a shift from just diagnosis and treatment of disease and osteopathically of thinking of the health and thinking of the person as the whole and seeing them in the context of their community. And so seeing more medical schools have social determinants of health as a part of that education, because I think especially during our first 2 years of medical school, we're still forming what does it mean to be a physician? What physician do I want to be? And if you have that early on in the education, then you're able to say, yes, a physician's responsibility is to advocate for their patients in their community, in their state, on the federal level, and be able to address those factors outside the clinic. And a project that I've been working on for a long time with, originally with Family Medicine for America's Health Policy team, is creating an advocacy curriculum so that students, originally that was for residents, but excited to create that for students that will be able to have an elective this next year in health advocacy for third and fourth years, and then working with Dr. Bilski and Dr. Sorrells and creating a curriculum during the first 2 years of training in health advocacy on how do you talk to a legislator? How do you write an opinion editorial? How do you dive deeply into something and look up things? What are the health policies related to a topic that's of interest, or something that you see that's a frustration in healthcare? Where do you start in being able to improve that? Where I think a lot of physicians or in our healthcare system there's lots of room for improvement. But not seeing enough physicians show up to the table to make those improvements. And I think a big part of that is we don't have it as a part of our education, so people don't know how to do that. And if we create that as a part of our education, viewing that as a doctor's responsibility to advocate for their patients and improve the healthcare system to make a better system for us and a better system for our patients.
Yeah, that's such a wonderful approach. It's got to be complicated in dealing with patients when you have the training that you get in medical school, which goes so deep into the way that the body functions and the things that can go wrong and the way that you can fix those things. And then you end up in a clinic and you find out that despite the fact that this person has something physically wrong with them, their physical problem, it may very well be caused by something that you have very little control over. That has to be such a frustrating and hard thing to deal with. And I imagine it results, there's so much burnout in physicians. We just recently had a podcast on that. I imagine that that's one of the results of that, is being able to help somebody through their health problem, but not being able to help them outside of the clinic where they really do need the help to prevent them from landing back in your clinic with another problem that's caused by many of the things that they deal with in their life that are difficult.
Absolutely. I think a big passion too of seeing with family medicine of primary care is really hard because you are addressing so many things. And one of the things that I am very excited to be a family physician, but something that I know going into it is you get less time than a specialist does to address the patient, organize their medications and organize all the things that the specialists are saying and seeing, does that medication conflict with another specialist medication? Being able to see them for preventative visits. So talking about are they smoking and how should they stop, talking about diet, coordinating the care in addition to, and they have a sore throat or they've got knee pain. And so that you're managing their medications, you're managing if they're seeing multiple specialists, you're managing their acute findings and maybe a 20-minute visit. And how do you do all that and the additional paperwork and charting? And I think that something that's really exciting to me with healthcare is switching from fee-for-service into more quality-based measures, which I think will be, so not just you came for this amount of time, you get paid for this amount of time, or you had this level of complexity of this visit, so I get charged this much, of looking at what's the impact and being able to switch from having diabetes be reimbursed a certain way, and then looking at how well is that patient progressing. There's definitely limitations to that, and I think it'll take a while to figure out, but I think that that's exciting. And I think the other thing with healthcare is with seeing classmates make a decision to potentially specialize, because there is so much responsibility and number of hours in primary care without the reimbursements. And so it's much easier to go into a specialty where you get more time with your patient, you get paid more, and potentially you have fewer hours. And so just thinking about that objectively, who's going to choose primary care? Where I feel very passionately about primary care, and I think osteopathically of being able to view the patient in the whole, and the frustration on certain rotations of, I love psychiatry and addressing people's mental health, but their mental health could be related to they just got a new medical diagnosis and now they feel really anxious about it, or that they started a new medication and now they have this side effect that they're seeing a different specialist for, but you missed it because you don't see the whole picture. And so with that, I think primary care should be a much larger part of our healthcare system and should be better reimbursed. And I think that that's not just for the primary care providers, but I think that's a better healthcare system for our patients.
Yeah, the close connection to somebody, and again, the impact that their lifestyle has on their health, it seems to go hand in hand in the sense that it makes sense to reward the people who are really investing in a patient's life, who are really caring for the person more than just whatever the patient presents with. It seems like something that, of course, you should do that, but it's strange that that's not the case. And coming from rural Montana and operating in that, what were some of the unique lifestyle challenges that you saw? Because our school operates in a sense of trying to take doctors and put them a lot of times in rural communities. And in rural communities, there are a lot of lifestyle pieces that are unique challenges to the people who live there. What were some of the unique challenges that you saw in those rural areas, especially coming from somewhere like San Diego that doesn't necessarily have those same challenges?
Yeah, and I would expand on our mission being rural and underserved, because I think that for me, I think serving in rural areas is a excellent goal, and I feel underserved encompasses rural as well as some of the populations or communities that are in an urban area but are not receiving healthcare, or at least in the same way that other people are. And so rurally with Montana, of going into some of those communities with healthcare, improving public health projects, of being able to work with Missoula Public Schools or work with Missoula Health Department and looking at the county instead of just in the Missoula city itself. I think for me, the biggest thing of seeing the housing of if somebody's homeless in a rural area, they're not on the street. And then being able to have access to healthy foods within a certain radius. And if somebody lives in a rural area and it's, so many miles to the grocery store, and now you're having to calculate how much gas am I spending to either go to the grocery store or get to a medical appointment, and seeing that access be limited, or with a healthcare provider too, if you only have one provider in the community and they're booked so many months out, where do you go? And so a lot of people just putting up with things that should be dealt with sooner. And then by the time that you come into the clinic, that things have progressed so far that it costs more to address that. And it's more severe for the patient rather than those preventative health measures too.
Now, all the work that you've done before even graduating from medical school, it landed you, as I started this conversation with, as our Student Doctor of the Year. But in being our Student Doctor of the Year, you entered this pool of a national conversation of Student Doctor of the Year across the country. And amazingly, you came as a runner-up in that, which of all the medical students across the country who are all doing, I'm sure, amazing things, what did it feel like to find out that you were named a runner-up across the entire nation, and how does that affect the work that you plan to do going forward?
A huge honor. A lot of my classmates at our school alone, I feel very honored to have been selected. A lot of people are deserving of that. It was a really nice recognition on that runner-up national level. And I think it's nice to be recognized personally, but also in having my passions and work be more in public health and advocacy, and see those things be appreciated and awarded is something I'm excited about. In addition to direct service that I've done volunteering at things in Yakima of either Union Gospel Mission or diabetes prevention program, or some of the stuff that I've done at CASA OGAR. That direct service has been great, but that's definitely been the bulk of the work that I've done is more in public health and advocacy.
So in being here in Yakima, you mentioned UGM. Your experiences from high school volunteering and doing all the work that you did to doing it in college to now doing it in medical school. How have you seen some sort of a shift in the climate of medicine, of healthcare, or has there been some sort of stagnation that's frustrated you that you hope to have some sort of an effect on? Or
I think vocalizing again of, well, I think when I was in college that I wasn't in the healthcare system, that I was a patient and saw people utilizing the healthcare system, but I think it's different now seeing it on a day-to-day basis, or seeing patients who have frustrations, or seeing some of those things that could be done better, versus advocating for Medicaid expansion when I was in Montana to have more access for more people to have health care. I think currently being able to advocate for affordable healthcare for all, whatever form that might be. I think we're still figuring out the best way to do that, but having access for everyone to quality primary care, and then being able to have bigger reimbursement for primary care, I think are two of the big goals that I have. There are many other smaller state policies that I'd advocate for. And one of the ones of the tobacco age being changed from 18 to 21, that was something advocating in Washington State a couple years ago. And that's super exciting that went through. So as advocacy goes, that those two being the bigger ones, but I think that sometimes advocacy can be, hey, there's this little issue that should be addressed. Or things like expedited partner therapy if somebody has an STD or STI, and of being able to have it so that they can have a drug so their partner can get treated without the partner coming in, of seeing things like that, of advocating to be able to have that be doable for the physician to do, that's a small thing that doesn't necessarily need to be a years-long project, that you could advocate the ones and potentially have the policy be able to go through. So I think whatever frustrations we have and being able to see how we can improve them.
I want to pose a question to you that you had brought up in and of yourself, and I bring it up because I'm very confident that you could answer it in a very well-rounded way. You talked about how specialties are more well-rewarded, both financially and because the workload is it's different. The patients that you're seeing, it's a different shape of scope of work. Why go into primary care, and why is it so important for people to choose that path when they could make more money and have a different sort of daily schedule and all the rewards that come along with going into a specialty? What is it about primary care that's so important?
Yes. With seeing family medicine for me, of going to a national conference and meeting a number of family physicians that were passionate, not just about addressing the disease, but addressing the patient in their community, and how do we advocate to have the best health for our patients and the best health for our communities and the best health for our nation. Those were conversations that I didn't hear as much outside of those conferences, and really meeting a lot of my mentors through those connections, and seeing family medicine as being this big leader, an American Academy of Family Physicians addressing health disparities as a big part of their mission, which is something I really admired. And so I think having that early on and being able to see, oh, that's the type of doctor I want to be. How do I become that? And so of being able to go on rotations and see physicians can be really considerate of their patients and not have that framework for how they could address the social determinants of health. And so I think primary care is really well situated to be able to learn about your patient and their whole, instead of, if you're a gastroenterologist, specifically what's happening with your stomach and your bowel movements, of being able to say, do you feel safe at home? Are you smoking? Are you able to exercise, and have that context of the whole, with the patients, and then be able to have one visit where you're talking about anxiety, and the next visit you're talking about knee pain, and the next visit you're being able to see them for a check-in and talk about their family or family planning. And I think in primary care, it's the unique opportunity to be able to see the patient as the whole, like we were saying, and that you miss that in the specialty. And that's something that's really important to me.
So you just brought up another point that I wanted to touch on, and I have to find it in my notes here. I don't have a set of notes, but with the list of accomplishments and things that you've done, I just had to make sure that I had them accurately.
Oh, thanks.
You mentioned serving on the AAFP Commission on Governmental Advocacy, and from reading about that, you were the only student that was serving on that commission. What was that experience like? How were you received, and how did you feel that your voice carried in that group?
Yeah, I feel extremely fortunate that last year I was the only student on the Commission on Public Health and or Science and Health of the Public is what it's called. And I felt very fortunate that I learned a lot through that experience, and also felt like my voice was heard, and that I brought a perspective that was still in healthcare, but not as far progressed, where I think sometimes it's harder for you to be able to see some of the things that once you're in that system of how can we change it, that it's been around for so long. And so writing guidelines on things like COPD, or writing a position on prostate-specific antigen of PSA, and being able to also talk about health equity in that last year was huge, and having these great discussions, and then how that translates to policies and also their lobbying efforts and what we were going to advocate for, and access to primary care healthcare being a big one. And then this year of being the only student on the Commission on Governmental Advocacy has been a huge learning experience. I'm going to be going to DC for the Family Medicine Advocacy Summit next week, and very excited I've had more experience on the state level and the community level, and to be able to go on that national level and meet with our representatives to talk about those things and hear their thoughts, and be able to build relationships to improve our healthcare system.
It's amazing. It's amazing that you're doing all of this as a medical student.
Oh, thanks.
And that so you are officially in your 4th year as a medical student, correct? And you are an undergraduate fellow in our OPP lab. Another major part of osteopathic medicine is the osteopathic approach also has manipulation in it. What is it that attracted you to be an undergraduate fellow in the OPP lab, and what is it about that sort of medicine? We had the conversation with Tom and Dr. Capistrant about FDM and about how it can improve patients' lives so quickly. And when you're in these rural communities that don't have access to care and don't have access to doctors, and the medications are really expensive, and the patients can't afford the treatments that they need, and there's some sort of a form of medicine that can really have a benefit to them very quickly and in a way that's accessible to them, that's such a powerful thing. Can you talk a bit about that?
Yeah, I find osteopathic manipulative treatment, OMT, to be a hugely powerful tool. That was a reason why I wanted to come to an osteopathic medical school, was having this tool of shadowing and seeing, wow, there's this thing that other doctors can't do, and it's with your hands, and you don't have to use outside resources, and you don't have to necessarily get the imaging or have a $5,000 procedure, and you could take somebody's pain away from 20 years in one visit. That's amazing, and I wanted to learn that. And so choosing to become a fellow, of wanting to deepen my skills, that every year you do OMT, you get better. And I've learned a lot through this year and really improved my techniques. I'm also really interested in teaching OMT or teaching in the future. And so that's been a great opportunity to get that exposure. And then the other part that we get to do is do OMT at Union Gospel Mission at the Free Clinic. And the patients that we get to work with are patients that I would like to work with for the rest of my career, of Spanish speaking. And I would not necessarily say that all of them are in a rural area, but definitely underserved, that they're coming to a free clinic because they don't have health insurance or they don't have enough health insurance, and they're coming to get that primary care or to get the health care that they can. And being able to do a technique where, especially in I speak Spanish, and being able to talk with them of they've had more experience with treatment with hands than they have with medications sometimes. And so being able to have a treatment that's almost more familiar to them than a lot of the things that we talk about that are common to us in healthcare, of workups with imaging and medications. And so my favorite story of the beginning of the year and being a fellow was a woman who was picking apples for her job and had an accident at work where she fell on her shoulder. And so she was only able to raise her arm to her shoulder and not past that, which for a job picking apples, that means that she's going to lose her job. And so being at risk of losing her job, losing her housing, expressing worries of not being able to feed her kids, put food on the table. And within that one visit of taking her, and I used FDM in that visit, of taking her shoulder from being at shoulder level to an additional about 90 degrees of motion, of getting it close to her ear and seeing her amazement as she was able to raise her arm up. And within the next visit it was a little less than it was before, but it was significantly improved. And within 3 visits, we got her back to where she didn't have any more pain, had full range of motion. And with 3 visits where you didn't have to do anything invasive, we didn't have to do extra medications, and some of the patients expressing that the medication is taking away the pain, but not necessarily addressing the underlying issue. And so being able to do that all with just my hands has been incredible.
That's amazing. And for somebody like that, that simple cure, which seems like it's just a shoulder injury, but that's not just a shoulder injury, that's her entire life. If she doesn't have something to fix that, or if she goes through many of the routes that would commonly be used to fix something like that, then she's out of work. And like you said, her not being able to do her job means that her entire family is losing out, and the health ramifications that come along with that, it's just like a tidal wave. So if that's not evidence of the power of the type of medicine and the approach that it takes to do this type of medicine, then I don't know what is. So as you go forward and as you start to approach graduation, which is exciting in and of itself, I'm sure. What are some of the things that you want to tackle, whether it's in advocacy or whether it's your approach to medicine, that you have sort of on your forefront of this is what I want to do as a doctor?
Yeah, I think I still have another year of rotations. This is my 4th year out of 5, since I'm doing an extra year of this academic medicine of being an OPP fellow. And I feel like I've really improved my OMT skills this year, and through the leadership positions that I've had, it's been great to be able to dive deeper into advocacy and continuing those efforts throughout this next year, applying OMT to the visits that I can when it's the appropriate action, which I think is more common than is being done currently. And looking further down the line of I plan to go to a family medicine residency and be that primary care doctor, and passionate about OMT, women's health, mental health. And then further in my career, I see myself potentially teaching at a residency, and then further down the line, potentially doing something with public health, at least if it's in my own volunteer time, or potentially part-time as a career in the future, of having that impact potentially on the state level, federal level, or working for something with effective altruism and having a global impact as well.
Well, Paige, just the opportunity to sit with our Student Doctor of the Year is such an honor. And then the fact that you're a runner-up for National Student Doctor of the Year is something else. And I think I speak for everybody at our university when I say that we're so proud to have you, and so proud to know that you're doing this great work, that you've done all this great work, and that you're going to continue doing more and more great things for the communities that you serve. So thanks so much for joining us for the conversation, and I look forward to talking to you more in the future.
Thanks so much for having me. It's been a pleasure.